Thank you very much for this kind invitation and for the great introduction. Today, I'd like to talk about my studies here at Barrow. What we're doing is I'm responsible from the cadaveric dissections and the exploration of dorsolateral brainstem approaches with a specific focus on microsurgical anatomical triangles. Yeah, so I have no relevant disclosures regarding this topic. I started working at Barrow Neurological Institute last year in 2024, and now it's been 1.5 years. And Barrow actually is a very good place that you can learn from masters. And I was so fortunate to learn from masters, Dr. Miranda, Dr. Spätzler, Dr. Tanikawa, Dr. Zabramsky, and this one on the below is our picture from microvascular anastomosis course. And a part of my job here, I also mentor medical students who visit Barrow during summer research times. So I'd like to begin with talking a little bit about our surgical anatomy laboratory. So what we do here is we have cadaveric specimens, and our lab is extensively rich with broad spectrum of cadaveric specimens. Those are very available here, and this is one of the specimens in the middle that I was exploring the floor of the fourth ventricle, and our my dissection pictures. Yes, the left-hand side, you can see our Zeiss TVs that the second assistants can watch during I'm performing some procedures. And from our dissection lab, our desks and the microscope. So what do we have? We have Zeiss Pentaro and Kinevo microscopes, along with Medtronic stealth station neuronavigation systems, Nikon cameras, and different kinds of illumination devices. Yes, this is from inside our dissection lab. This is the dissection desk that I'm usually working at. And we had, as I said, different types of cadaveric specimens, formalin fixed or non-fixed, according to what we're studying exactly. For example, during our 7-test MRI ultra high resolution anatomical studies, we are using non-fixed specimens sometimes, and we are using latex injected or non-injected heads. Or sometimes the heads we are using are slightly formalin flash but not fixed, and we preferably use low post-mortem interval cadaveric specimens. This is a picture example that I took last year. I'm showing this picture to illustrate the effect of latex injection and not latex injection during cadaveric dissections. This is much more easier. In non-injected specimens, it's kind of much harder to navigate because the cadaveric tissue obviously becomes harder, and it becomes really difficult to understand if those vascular structures are veins or arteries or whatever. And this is other cadaveric picture that I took last year. And here you can see the both vertebral arteries, the basilar artery, and the origin of the pica and 7 and 8 nerve, cerebellar flocculus, along with the lower cranial nerves, 11th nerve, 9th and 10th nerve, and a beautiful specimen, good injected, a high quality specimen. And you can see obviously the pontine underbelly and the pontomedullary junction. So part of my job, what I'm doing here is I'm exploring the taxonomy that's been developed by Dr. Michael Lawton. So brainstem cavernous malformation taxonomy have been developed by our institute here at Barrow by Dr. Lawton and his team. So these are the milestone articles. If any one of you like to learn more about these triangles and the safe entry zones, I strongly urge you to read all these articles, because this is the milestone article that I'm always using. I keep using, and this, for example, brainstem cavernous malformation subtypes for pontine lesions, part 1. We have pontine lesions, part 2. We have midbrain lesions. We have medullary lesions. We have thalamic lesions. And basically, we have everything. If you want to learn more about this presentation, I strongly urge you to read these articles. Okay, on the right-hand side, this is the taxonomy developed by Dr. Lawton and his team here at Barrow. First, we see midbrain cavernous malformations, pons, and medullary cavernous malformations. Midbrain cavernous malformations can further subdivide into quadrigeminal, tegmental, peduncular, and interpeduncular subtypes, whereas pontine subtypes can be divided into basilarly, peritrigeminal, rhomboid, middle peduncular, inferior peduncular, and supraolivary subtypes, whereas medullary cavernous malformations can be divided into trigonal, cuneate, gracile, olivary, and pyramidal subtypes. And as you can see in this diagram, so we know which craniotomy we want to use, which approach we'd like to use, and to rule what triangle we can reach out these safe entry zones. This is the most important stuff. For example, I previously worked on these supracerebellar, supratrochlear, and supracerebellar infratrochlear triangles. We explored their utility while approaching the dorsolateral midbrain cavernous malformations via lateral mesencephalic sulcus. And also we worked on pontine subtypes, and mostly we worked on peritrigeminal ones and inferior peduncular and supraolivary ones. For inferior peduncular one, we use standard midline suboccipital craniotomy and suboccipital transventricular approach and molecular triangle. I'll show you our exploration of all these triangles in a minute. Okay, so what is an anatomical triangle? Anatomical triangles are surgical corridors defined by intersecting neurovascular bundles. They can help guide us navigating through deep-seated targets. And there are a bunch of anatomical triangles defined before. You can see some of them in these diagrams. These diagrams belong to Barrow, Mr. Peter Lawrence. And this is, for example, carotid oculomotor triangle, oculomotor tentorial triangle, vertebral basilar junctional triangle, interlobular triangle, Cavazze triangle, glossopharyngeal cochlear triangle in between the cranial nerves here. And here you can see the supracerebellar infratrochlear triangle, supracerebellar supratrochlear triangle, infragalenic triangle, subtonsillar triangle, and vallecular triangle. I'll show you further what we aim to explore here by doing this. Yes, anatomical triangle concept closely resembles to using a rifle, right? One can easily imagine that these rear sides can be the craniotomy and approach, whereas this front side is anatomical triangle. And our aim on the brainstem is somewhere over here. Okay, these are the triangles that can be used while approaching the midbrain cavernous malformations. I specifically worked on, with the help of Dr. Şahin Hanaloğlu, by the way. I have to thank Dr. Şahin Hanaloğlu from Hacettepe University, who was here at Barrow before me and who started some of these projects, and I continued these projects. So, supracerebellar and supratrochlear triangle has three edges in medial, superior, and inferior. Medial border is defined by the lateral side, the lateral border of the tectum. Whereas on the superior side is tentorium, and the inferior side there's trochlear nerve. It's the widest in posterior incisorial space. It can be best accessed via paramedian supracerebellar infratentorial approach, and it can grant access to lateral mesencephalic sulcus safe entry zone. Whereas the infratrochlear triangle is bounded by anterior superior, posterior superior, inferior edges. The anterior superior edge is free edge of tentorium. Posterior superior edge is defined by the fourth nerve, whereas the inferior edge defined by the quadrangular lobule. It's widest in the middle incisorial space and can be best accessed via lateral supracerebellar infratentorial approach. And again, it gives access to lateral mesencephalic sulcus safe entry zone. What about for the pontine ones? As I said, we have Cavazze, supratrigeminal, infratrigeminal, glossopharyngeal cochlear, and interlobular triangles. Lately, I performed dissections for all these triangles and start with supratrigeminal one, bordered by posteriorly cerebellar quadrangular lobule, superiorly tentorium, inferiorly the fifth nerve, the trigeminal nerve. It includes crucial anatomical structures such as Meckel's cave, suprapetrosal sinus, Dandy's vein, cerebellar artery, S3 segment, and it gives access to supratrigeminal safe entry zone. What about the infratrigeminal one? It's bounded by superiorly the fifth nerve, posteriorly cerebellar quadrangular lobule, inferiorly eighth nerve, anteriorly petrous bone, and it includes crucial anatomical structures as well, such as porus trigeminus, porus acousticus. And it's the largest, maybe the most important thing here is the infratrigeminal corridor is the largest corridor to anterolateral pons. And it can grant access to infratrigeminal safe entry zone. What about the glossopharyngeal cochlear one? It's bonded superiorly by acoustic fascial complex, anteriorly by petrous bone, inferiorly by the glossopharyngeal nerve, and mostly Dr. Lawton utilizes this triangle to reach out high riding pica aneurysms, which is defined by approximately 21 millimeters above the foramen magnum. And it can give access to pontomedullary sulcus safe entry zone. What about the medullary subtypes? As I said, there are many different types of medullary ones. These red-crossed ones are the ones that I explored. Vagal accessory suprahypoglossal triangle, bonded medially by the midline of the medulla, superiorly by the vagus nerve, laterally by the accessory nerve, and inferiorly by the hypoglossal nerve. And it includes, and it can give access to different and very crucial anatomical structures, and also the pontomedullary sulcus safe entry zone. What about the vallecular and subtonsillar ones? Vallecular triangle defined by superiorly uvula of the inferior vermis. Laterally from both sides, both edges of the cerebellar tonsils on both sides. An inferior line between the inferior extent of both cerebellar tonsils. And by utilizing this vallecular triangle, we can reach out to the fourth ventricle, obex, rhomboid fossa, gracile and cuneate nuclei, and P3 segment of pica. And there are multiple safe entry zones that we can reach out while using the vallecular triangle, such as median sulcus, infrafacial collicular sulcus, infrafacial collicular, and posterior median sulcus. What about the subtonsillar one? Subtonsillar triangle can only be exposed by dividing the inframedullary velum and telechoroidea. And it defined medially by the midline, superlaterally by the retracted edge of the medial border of the tonsil, inferiorlaterally by the divided telechoroidea. And while using this subtonsillar triangle in televelar approach, we can reach out to lateral recess of the fourth ventricle, cerebellar medullary cistern, and foramen of Luschka, along with P3 and P4 segments of pica. And there are two safe entry zones that we can reach out while using this triangle, such as area acoustica and posterior intermediate sulcus. So what about the subtypes of lesions that we can reach while utilizing these triangles? In midbrain, while using supra and infratrochlear triangles, we can reach out to tegmental subtype of midbrain cavernous malformations. In pons, while utilizing these supra and infratrigeminal triangles, we can reach out to peritrigeminal type of cavernous malformations. And what about for inferior peduncular subtype of cavernous malformations? We should use subtonsillar triangle. For rhomboid ones, vallecular triangle. For supraolivary cavernous malformations, we should use vagal accessory suprahypoglossal triangle. And for trigeminal ones, vallecular, gracile, vallecular, and cuneate lesions, we should use subtonsillar triangle. Okay, if you want to learn more about these triangles and their matching approaches and craniotomies, I strongly urge you to read the articles that I showed in the beginning of my speech, and those articles include all the tables and details about all these triangles. So this was the first project that I completed during my time at Barrow. These include supra and infratrochlear triangle. So if you can see the image, the cadaveric image here that I've driven, so you can see the fourth nerve, the trochlear nerve, and above it, we have supracerebellar supratrochlear triangle. He bonded medially by the lateral side of the tectum, superiorly by the tentorium, and inferiorly by the fourth nerve. And this is the supracerebellar supratrochlear triangle. What about the infratrochlear triangle? It's bonded superiorly by the fourth nerve, and posterior superior, anterior superior by the cerebellar quadrangular lobule and the tentorium. Here you can see the borders. Supratriangle is widest in the posterior incisorial space, whereas the inferior triangle widest in the middle incisorial space. And this black arrow here shows the trajectory of the approach that we're utilizing, that we're using, and we are aiming to reach out here, the tegmentum of the midbrain. Yeah, this is a close-up view that what I just showed you. You can see the colliculi here, medial and lateral geniculate bodies here, pineal gland here, the dorsolateral midbrain here, and along with other structures such as middle cerebellar peduncle, the superior cerebellar peduncle, and among others. So, as Dr. Michael Lawton and the Barrow team defined, if you can see on the right-hand side, this is the midbrain cavernous malformations. So number 2 is peduncular subtype. Number 1 is interpeduncular subtype. Number 3 is tegmental subtype. Number 5 is periaqueductal subtype, whereas number 4 is quadrigeminal subtype. When you take a look at the CT or MRI, and if you can locate the lesion, then just follow your Sankey diagram, and you'll be able to see all the triangles and corridors that you can use while approaching these types of cavernous malformations. So, supratrigeminal triangle gives access to quadrigeminal cistern, posterior segmentum, P2 and P3 segments of the posterior cerebral artery, and actually it's midbrain above the basal vein of Rosenthal. It can be best accessed via paramedian supracerebellar infratentorial approach. Whereas the ITT gives access to ambient cistern, cerebellar mesencephalic fissure, anterior tegmentum, S3 of superior cerebellar artery, circumflex perforators, obviously, and lateral mesencephalic vein. Can be best accessed via lateral supracerebellar infratentorial approach. This is the animation driven by our office. Our office made this animation. This is to show our approach here we used. The triangle above is the supracerebellar, supratrochlear triangle, whereas the inferior one is infratrochlear triangle. And you can see the crucial anatomical structures in relation with both of these triangles, such as medial lemniscus, crus cerebri, middle and superior cerebellar peduncles. So what we did use in this project, we did dissect 5 formalin-fixed cadaveric heads. They were, of course, latex injected. We used standard retrosigmoid craniotomy and lateral supracerebral infratentorial approach. Then, during the approach, we took quantitative neuronavigation measurements. We did measure the neuronavigation points like X, Y, Z coordinates under standard and expanded brainstem exposures. So what do I mean? Imagine the triangle. We measured triangle's edges. Also, we defined the midpoints of the edges of the triangles. While using our surgical instrument, we retract the midpoint of these triangles and we create an odd-shaped new area for brainstem exposure. So what we did here is we tried to compare the brainstem exposure areas before and after retraction to say if retraction is significantly improving the brainstem exposure area during these approaches. Okay. And then we did use 3D modeling and simulation along with tractography and 7 Tesla MRI. This is the hockey stick incision that we used during these dissections. Why hockey stick is a good question. Just to be more efficient because it's a cadaveric specimen, and as you all know, cadaveric specimens have all hard tissues, and sometimes exposure can be hard, and that's why we just use we did not use the standard retrosigmoid secant incision, but hockey stick incision. That was the only reason. Then we did use standard retrosigmoid craniotomy and inverse U-shaped dural incision. This is the approach trajectory that we use to reach out the tegmental brainstem. And the illustration on the right hand side has been taken during the cadaveric dissections. You can here see the supratrochlear triangle, tentorium, and the very important thing is rostral trunk of superior cerebellar artery is inside the supratrochlear triangle. And here on B, C, and D, you see the infratrochlear triangle. And the caudal trunk of supracerebellar artery lies inside the infratrochlear triangle. That's another very important thing. And also, I'd like to stress you to see this lateral mesencephalic vein here, because lateral mesencephalic vein shows us where exactly the lateral mesencephalic sulcus is. And during these approaches, our aim is to reach out a safe entry zone. And that lateral mesencephalic vein help us guide, help us find the safe entry zone. Uh, and that's our entry point in most of the instances. Yes, these are the quantitative measurements that we took under neuronavigation. We always use nearly the same methodology. So what we did here is we did measure triangle edges, medial edge, inferior edge, and superior edge defined by these structures, and we find their values, along with vertex angles for both of the triangles. And then we did some comparisons. So for STT, under standard exposure, this is our area of exposure of the triangle. And after the retraction, after the expansion, here we nearly doubled the exposure of the triangle. And these are the brainstem exposures. Under standard conditions, without retraction of the edges, this is the exposed area. And with expanding brainstem exposure, with retracting the edges, here you can see we almost tripled the brainstem exposure area. These were the certain points that we collected neuronavigation measurements during our study, like V1 through V7. These are predefined points such as fourth nerve's brainstem entry, fifth nerve's entry, or V7 is defined by the intersection point between the trochlear nerve and lateral mesencephalic safe entry zone. Yes, these are the measurement points that we took. And like I said, from the midpoints, via using our instruments, we did some retractions to create the expanded exposure on the brainstem. Like I said, these all illustrations belong to Barrow, by the way, driven by Mr. Peter Lawrence. So this lateral mesencephalic vein, like I told, shows us very exactly, guys, the lateral mesencephalic sulcus safe entry zone. And this is a nice illustration depicting the area that we're approaching. And I'd like to stress you to see the S3 segment of this SCA, P2 segment of posterior cerebral artery, along with colliculi. And here is the dorsolateral midbrain area that we're trying to approach. Here in this publication, you can read more. These are the 3D illustration models that we try to depict, that we try to illustrate to better understand the brainstem exposure areas that we can reach out while utilizing these approaches. So on the left-hand side, what you can see is this is the obviously trochlear nerve. This is the rostral trunk and caudal trunk of the supracerebellar artery. And this green triangle is the area that we can reach utilizing the supratrochlear triangle. This light blue triangle is the area that we can reach using infratrochlear triangle without any expansion. And we took some pictures from different angles. On the right-hand side, the ones above shows us the expanded exposure, how much the instrumental retraction increases the brainstem exposure area. This yellow one is before the retraction, and this orange one is after retraction. And here you can see how much we can increase the brainstem exposure area while retracting our anatomical structures. And the ones below are infratrochlear triangles. And the blue one is before retraction, and the purple one is after retraction, and here you can see how much we can expand the brainstem exposure area. And here you can see actually we cannot really expand this inferior triangle as much as the superior one, and there are some reasons, anatomical limitations around these triangles. And we did tractographies to illustrate what white matter tracts lies in close proximity with these triangles. Spinothalamic tract, crus cerebri, lateral lemniscus, trigeminal mesencephalic tract, among many others, lies in close proximity with this triangle. So we rather have to be very careful during the surgical actual exploration. These are 7 Tesla MRI illustrations, along with the corresponding fractional anisotropy mappings. The red one, the red arrow, depicts the paramedian supracerebellar infratemporal approach, whereas the white one depicts the lateral supracerebellar infratemporal approach. So as conclusion for this triangle, I'll go on, I'll continue with other triangles. So these both triangles can be used to reach out ambient cistern and dorsolateral midbrain pathologies, particularly for tegmental midbrain cavernomas. And we can expose this triangle through retrosigmoid approach and retrosigmoid craniotomy and supracerebral lymphotemporal approach. And this can give access to lateral mesencephalic sulcus safe entry zone. We should pay attention to rostral and caudal trunks of SCA, of course, and P2 segment of PCA. And keep in mind that spinothalamic tract, lateral lemniscus, and trigeminal lemniscus lies in close proximity. We published this. If you want to read more, this is in this article in Neurosurgical Review. Next triangle is subtonsillar and vallecular triangles. So these are the beautiful cadaveric pictures that I took again maybe 10 months ago. And you can see the floor of the fourth ventricle here, median sulcus, facial colliculi, sulcus limitans, stria medullaris. And here, the blue dashed triangle is the vallecular triangle. As you all know, vallecular is normally closed. During a midline suboccipital approach, we first need to expose the cisterna magna and find the cerebral tonsils and retract the tonsils. By retraction, we open the vallecula and we can create this triangle defined by the both sides of cerebral tonsils and the line between the inferior extent of the cerebral tonsils and inferior extent of cerebellar vermices uvula. And here within this triangle, you can see the hypoglossal and vagal trigones along with obex. And this triangle is expandable. I'll show you more illustrations. And this can be utilized during transvermian and transventricular approaches. Dr. Lawton likes to call transventricular approach. Transvermian approach goes towards vermis, whereas transventricular approach goes directly towards the floor of the fourth ventricle. Yeah, and on the B, you can see again the floor of the fourth ventricle. Stria medullaris here, the facial colliculi is here, median sulcus is here. This is the subtonsillar triangle, can be defined and reach out via dividing telechoroidea and inferior medullary velum. And this is a triangle that you can create during your dissection. Okay. As I said, vallecular triangle is defined by medial surfaces of cerebellar tonsils, inferiorly the line between the inferior extent of cerebellar tonsils, and it can give us access to caudal loops and distal P3 segments of pica, along with upper rhomboid fossa. Via retracting more of these tonsils, you can reach more above. Whereas subtonsillar triangle is defined by the midline, inferior laterally by of the fourth ventricle, divide telechoroidea, superlaterally by the ipsilateral cerebellar tonsil, and it can give us access to cerebellomedullary cistern, distal P3 and proximal P4 segments of pica, along with ipsilateral foramen of Luschka. And this we can use this triangle, particularly during suboccipital televolar approach for inferior peduncular and cuneate subtypes of pontine and medullary cavernous malformations. Again, we used 5 formalin fixed cadaveric heads. Our approach was the same, suboccipital craniotomy and C1 laminectomy, and we followed subvictory. We did the same thing. We did neuronavigational measurements under standard and expand conditions, and we did 3D modeling and tractography along with 7 Tesla MRI. This is the illustration of our exposure here. Here you can see the big vallecular triangle, whereas the small subtonsillar triangle, and you can see the surrounding white matter tracts, which are lying cross proximity, of course, because we're working on the floor to fourth ventricle. Here you can see the vestibular complex, inferior cerebellar peduncle, MLF, central tegmental tract, along with hypoglossal and vagal trigones, and cuneate and gracile, obviously. Okay, we did use the linear midline skin incision, T-shaped muscle splitting, and standard midline suboccipital craniotomy along with C1 laminectomy. And we did Y-shaped dural incision, and we reach out to cerebral tonsils, and we opened cisterna magna, and we exposed the vallecula via the help of these both-sided retractors. This is obviously the floor to fourth ventricle, and this is the first exposure of the vallecular triangle, defined by all of the vermis, both tonsils, and the inferior line between the inferior extents of cerebral tonsils. And you can see the structures that we can reach out by utilizing this triangle. And look at the right side. This is upon further retraction. I retracted the cerebral tonsils further, and you can see how much superior access it can give us up until the facial colliculi. And in the inferior side, sorry, I'm trying to, yes. In the inferior side, in the image C, you can see the subtonsillar triangle along with the retracted ipsilateral tonsil, midline, and divided telachoidea. So what we measured here in this study is, again, the edges, the medial, superlateral, and infralateral edges of the triangles, along with the vertices. Yeah, you can see before and after retraction. Then we compared if there is anything statistically significant. As you can see, the area of the triangle, this is for the vallecular triangle, was 38.4 before retraction, but nearly 3 times increased, so nearly 130, and this is statistically significant. Our 3D models. On the left-hand side, you can see our craniotomy. This is gray-shaped frame. This is our craniotomy. And you can see cauda opica, and this is the vallecular triangle that we exposed. And the one below shows the subtonsillar triangle, which we can create via retracting ipsilateral cerebellar tonsil. On the right-hand side, you can see one above is the brainstem surface area, the dorsal floor to fourth ventricle surface area that we can reach out by utilizing vallecular triangle before retraction, and this is after retraction, to illustrate how much more brainstem exposure area that we can create after retraction. And the one below shows the subtonsillar triangle. Again, here the green arrow depicts the transvermian and transventricular approaches, whereas the red one depicts the telovelar approach. And these are the corresponding axial scanner to 7 Tesla MRI, whereas the right ones are corresponding fractional anisotropy maps. As you know, this is according to the directions of the white tracks that lies here. And this one is the vallecular triangle. You can see all axes inside, and these white dashed triangles are subtonsillar triangles. Again, we performed tractographies to illustrate the white matter tracks lying in close proximity to this triangle. You can see the yellow dashed lines are vallecular triangles. And you can see interarcuate fascicles, CST, and many other white matter tracks lies in close proximity to these triangles. So to conclude this triangle, so ST and VT through midline suboccipital craniotomy and C1 laminectomy, we can utilize these both triangles during suboccipital transvermian, suboccipital transventricular, and suboccipital telovelar approaches to reach out dorsal medullary, inferior peduncular, trigonal, rhomboid, gracile, and cuneate lesions. These are subtypes of cavernous malformations. SC gives us access to posterior intermediate sulcus and area acoustica safe entry zone, whereas vallecular triangle gives us access to median sulcus, suprafacial collicular, and superior foveal safe entry zones. These both triangles are reliable triangles that we can utilize while approaching different types of brainstem cavernous malformations. And we published this as well. If you'd like to read, this is in Neurosurgical Review. And we did 3 more. This is glossopharyngeal cochlear triangle, defined superior by the 8th nerve, inferior by the 9th nerve, anterior by the petrous bone. And this is a beautiful illustration that I took maybe 3 or 4 months ago. And this is the glossopharyngeal cochlear triangle and the labral nerves, obviously. And we did the same thing. Retracted the glossopharyngeal nerve here to illustrate better the exposure area. Here in this study, what we did first, we performed standard retrosigmoid craniotomy, and we measured surgical freedoms. Then we expanded the craniotomy, extended the retrosigmoid craniotomy, and we again retook the measurements and we compared if the conditions differs. And this is the surgical freedom measurement that we use. I learned this when after I come to Barrow. This was a traditional technique that's been used in the laboratory that I'm working on. So please take a look at here. There's one target point. This can be on one of the safe entry zones, such as pontomedullary sulcus safe entry zone, let's say. Under the pontine underbelly, you can just point your surgical instrument somewhere here, and you need to create a conical shaped geometrical shape, and you will be collecting inferior point, superior point, lateral point, medial point, and points in between. While performing that, you collect 8 neuronavigational points, and it can give you a conical shaped surgical freedom volume. And while creating this volume, we can better understand if standard retrosigmoid craniotomy is enough or extended one is needed. And this is an illustration, an example of one of the exercises that we are using during our navigation measurements. Of course, this can be done in many different types and techniques, but this is the formula that I always use. For cadaver one, left side, right side, XYZ coordinates, this is the approach, extended or standard approach. And I usually define 4 points on bony craniotomy borders, like left superior extent, superlateral, superior medial, infralateral, and on the dura as well. Then we reach out to the triangle, like the analogy I've given you with the rear side and the front side of a rifle. This illustration is prepared by our Barrow Neuropublication Office. A beautiful one. As you can see, this is the glossopharyngeal cochlear triangle that we can reach between the 7 and 8 nerve complex and the 9th nerve. This is the area that we are working on. And we specifically utilize the glossopharyngeal cochlear triangle to reach out to high writing, pica, and nervisms. And what about this triangle above? So this is the infratrigeminal triangle, supratrigeminal triangle, glossopharyngeal cochlear triangle, and this is, for example, vagal accessory triangle. I will show you in a minute. Yes, this is the extended retrosigmoid approach that we used in this study. Here you can see the glossopharyngeal cochlear triangle that we exposed. Yeah, we submitted this to North American Skull-Based Society. It's been accepted. It's going to be an oral presentation in upcoming March in San Diego, California. The next project was supra and infratrigeminal triangles, like I showed you a minute ago. This is a supratrigeminal triangle that we can reach out through extended retrosigmoid craniotomy again. This is my retractor and quadrangular lobulocerebellum, tentorium, fifth nerve, and you can see this is the infratrigeminal triangle, and it's obviously in between the fifth nerve and 7 and 8 nerve complex, anteriorly bound by petrous bone, whereas posteriorly by the cerebellar quadrangular lobule. Again, we perform the same thing. While retracting the edges of the triangles, we intend to create an expanded brainstem exposure area. And while doing so, we try to understand how expansion or how retraction helps us during the actual surgery in terms of increasing the brainstem exposure area. Yeah. These are Dr. Lawton's examples I took from one of the articles that I showed you in the beginning of my speech. This is extended retrosigmoid craniotomy, and we are using the supratrigeminal triangle, and we are trying to reach out at peritrigeminal pontine cavernous malformations. Here you can see the fifth nerve. The fourth nerve here obviously lies close to the tentorium, and this is the triangular shaped area that we are trying to reach. This is again extended retrosigmoid craniotomy. We're utilizing here is infratrigeminal triangle to reach out again a peritrigeminal cavernous malformations. Here you can see the fifth nerve, here you can see the 7 and 8 nerve complex, and this is the infratrigeminal triangle. And this is again the extended retrosigmoid craniotomy, but this time is glossopharyngeal cochlear triangle. Again, we are reaching out to peritrigeminal cavernous malformations. This is the illustration that we created for this project. Here you can see the supratrigeminal triangle and infratrigeminal triangle. And these are all these white matter tracts lies in close proximity, of course. We need to be taken care of. Again, a beautiful illustration made by our neuropublication office at Barrow. Supratrigeminal triangle and infratrigeminal triangle through an extended retrosigmoid craniotomy window, and you can see the surrounding crucial anatomical structures. And this is the illustration depicting our reach to supra and infratrigeminal triangles. You can see the cranial nerves and the surrounding white matter tracts. This is also accepted by North American Skull-Based Society. We'll be presenting this in upcoming March in San Diego, California. The other one we exposed was through far lateral approach, far lateral craniotomy, transpontomedullary sulcus approach. As you can see here, this is our approach trajectory, and this is vago-accessory triangle, defined by 10th nerve, 11th nerve, midline of the medulla, and obviously the 12th nerve divides this triangle into two parts, suprahypoglossal and infrahypoglossal triangles. And this is again taken by taken from one of Dr. Lawson's surgeries. And here you can see the vago-accessory triangle. This is vagus and 11th nerve, obviously. This is the methodology that we used in this paper. This is the hockey stick standard incision for far lateral approach, and this is the craniotomy borders. Of course, we did C1 hemilaminectomy to complete the approach. We mobilize the vertebral artery. Then this is the U-shaped dural incision that we used. Here, dura is exposed, and after dividing the denticulate ligament, we start our subarachnoid dissection to reach out the structures that we intend to reach. And this is the exposure trajectory that we have used in this study. This is a good picture that this is one of my initial trials when I first arrived to lab. And this is from the posterior side. I was trying to illustrate the retrosigmoid approaches and far lateral approaches stand of view. Here you can see the pons and pontine underbelly. And this is actually the triangle that we are trying to use here. This is the triangle, vago-accessory triangle. And while using this triangle, especially the part above the hypoglossal nerve, we are reaching the pontine underbelly and pontomedullary sulcus to resect supraolivary located cavernous malformations. Again, we did 3D illustrations to better understand these triangles. Here you can see the vago-accessory triangle, and this one below is the suprahypoglossal part of the vago-accessory triangle. This is again from Dr. Lawton's far lateral craniotomy, vago-accessory triangle, suprahypoglossal triangle, to reach out olivary medullary cavernous malformations. And here you can see this is the vago-accessory triangle. This is the midline of medulla. This is vagus nerve. This is accessorius. And here you can see the 12th nerve dividing this triangle into two parts. This is the inferior part and this is the superior part. To reach out the pontine underbelly, we have to use the suprahypoglossal triangle. And this is again beautiful animation, again made by Barrow Publication Office. This is the suprahypoglossal and infrahypoglossal triangles that we have used during approaching these lesions. This is again accepted for North American Skull-Based Society. Thank you very much. I don't know, maybe it was too long. I don't know, but this is the end of my presentation. I'd like to thank Dr. Hanaloğlu because, as I said, first two projects he started here, and when I first arrived Barrow, by communicating with him, I continued these projects, and he was always very helpful and supportive. Of course, Dr. Michael Lawton and all Barrow office, Barrow Neuropublication office, and my mentors at Barrow Neurological Institute, Dr. Mark Proul. He's the director of the lab that I'm currently working on. Thank you very much. I hope you
Thank you.
enjoyed the speech.
Thank you very much. It was actually very enjoyable, and even like med students like me understood some aspects, honestly. So basically now the floor is open for questions. You can write down your questions to Dr. Yangı about the presentation to the chat. And please don't forget to include your name, institution, and city, and I will just relay them. Meanwhile, we are waiting for the questions. I think I could use some moderator privileges myself and ask the first question. So basically,
Sorry, Gasimova.
yeah.
Dr. Yangı, please, can you stop your screen sharing? So
Oh, of course. Yes. I'm sorry.
no, not at all. Okay.
Sorry for that. Okay, so basically, honestly, for myself, tractography is something literally feels like out of sci-fi, movies. So with like the advent of like new technology and everything else, do you think like all these classical anatomical triangles that you discussed in this presentation remain valid in the presence of individual tractography based variations, or should the safe entry zones be redefined on the patient specific basis? Does that make
Thank you very
sense?
much. Yeah, a very good question, actually. Yeah, of course. I mean, in cadaveric studies, we have limitations, of course. For example, the first limitation is the tissue is not soft, tissue is hard, and there is no CSF, there is no blood. So that's the main limitation that we are facing with. In the actual surgical scenario, it might be different, but what we're trying to say is it may be minimally different. Because we're trying to illustrate these triangles, and these triangles are being defined by the constant neurovascular structures, such as the cranial nerves. They of course they have variations, but actually I think in most of the scenarios we may have to see them. There are I'm also seeing my professor from my faculty here, Dr. Suat Erol Çelik, is also here. There are many experienced surgeons here more than me. They can explain further, I believe. But I think these triangles are valid and can be used during approaching these cameras malformations. At least this is what I learned from Dr. Lawton. And in most of the surgeries, he uses the analogy with the rear side and the front side of the rifle while approaching these areas, because obviously in many places in the earth it's still one of the hardest pathologies, the brainstem camera malformations, obviously, and the tractography based studies. Why we are doing it for is we try to understand what might happen if we danger or if we injure the surrounding structures. And to understand that better, we're trying to illustrate the 3D surgical anatomy. And that can also variate from person to person, or some expensive pathologies can differ and can affect the anatomy of the region. Yeah, but I think these triangle method are still valid and can be used in approaching these different types of cameras malformations.
Okay, thank you very much. We have another question in the chat. So it is from Dr. Selim Bozdağ, who's also a faculty member in our university. Great work, congratulations. Could you briefly tell the opportunities for medical students to work in laboratories abroad? Very good question to be fair.
Yeah, of course. So This is a good question, actually, and there are many different opportunities, but it depends on the lab. For example, in Turkey, I was trying to find some place that I can practice to learn these different techniques, but it was kind of hard to find places that you can actually dissect and learn the anatomy. So I used my international contacts. As you said in the beginning, I first started to come abroad in 2012, like 13 years ago, and that made me a circle. So I know people from United States, from Germany, from many different parts of the world. So I said, maybe I should try my chance in United States. United States always was in my mind to come and pursue my studies, to continue my studies, maybe to continue my academic career at all. So then I applied to a position at Barrow, and I was fortunate to be accepted. But for example, these conditions in my lab, the acceptance eligibility criteria, you have to be at least came towards the end of your residency, because they're looking for some people who can come here and perform dissections. And my primary duty is the dissections that I presented today. I need to perform them. I need to write my manuscripts. I need to publish all these. And I need to be able to dissect these triangles and expose these triangles and brainstem safe entry zones and perform all these approaches. Is it easy? Of course it isn't. It is not. When I first arrived here, I learned. I practiced a lot. Am I perfect now? No, obviously not. I'm still learning. I'm performing more and more approaches. But the conditions, the eligibility criteria of my lab was you should at least be mid-level or mid to high level in neurosurgery residency. Otherwise, they will not accept. But every summer, we accept medical students throughout the United States and throughout the world. For example, this summer I had one student from Hacettepe University from Turkey. I mentored them. We collectively write systematic review articles, meta-analysis. I help them learn anatomy, and they can attend my dissection sessions, and that's how it goes. For medical student years, I was visiting different hospitals in United States and also in Germany. But my first place that I worked was Mayo Clinic, actually. I worked at Rochester Mayo Clinic for a while, and it was 2016. And on those days, I decided, yeah, one day I should come to the United States to pursue my career, perhaps. And that's how I decided. And you can also follow those types of opportunities. You can apply to spend 1 month of or 2 months or 3 months of observerships in good clinics. For example, Barrow accepts observers. Not mainly from medical students though, but you can still accept to come here and learn the concepts, because I know some medical students who came to Barrow last summer. They reach out to me nearly always. I meet them, I show them around and stuff. So you need to be aware of your opportunities and try to apply as many positions as you want if you like to come to the United States and pursue a medical career, or at least learn something during your medical school.
Thank you. So the next question is, thank you very much for the presentation, Dr. Yangı. As a medical student, I may not have understood every detail, but it was very inspiring and insightful. My bad, it was not a question. We have another question from Dr. Selim Boza. Do you have any practical tips or tricks for beginners to improve the quality of anatomical photography?
Anatomical photo, very nice question, Dr. Boza. Thank you very much. At first, I had so much trouble shooting these pictures. These pictures that I showed you, maybe every single one of them took weeks to shoot great pictures. The illumination is very important. The devices that you use is very important. In our lab, we have very different types of illumination devices, like circular devices that we can actually work through the circular device, so it illuminates all the area. And we have Nikons, and we have different types of illumination devices. So in order to take 3D pictures, a good quality pictures, now one of my tips is Actually, iPhones take very high quality pictures. So if you have iPhone 16 or iPhone 17, and there are some certain apps like 360 photography apps, I can look through it and give the exact name of the app that I'm using. And while using those apps and your iPhone, you just took as much pictures as possible, like 360 in a good illumination. And while using the help of those apps and some AI apps, it actually can give you um, great pictures. So one of my tips would be using your iPhones, and maybe sometimes instead of Nikon photograph photo machines, because when it's too deep in the brain, the exposed triangles sometimes are very deep, and if the microscope that you're using is an old version, let's say, the picture might not be highly illuminated or a good picture. So to do that, you need to use additional illumination devices, circular illumination devices. Maybe you can work through it. Or if you have the opportunity, sometimes I'm fortunate to have the opportunity to take the most recent microscope from the operation room, Zeiss Kineo 900S, and Dr. Lawton and the team use the good microscopes. So sometimes I'm fortunate to use them and via the microscope, so I can take high quality pictures. But other than that, you need to have some equipment. If you don't have equipment, you use your iPhones. That's one thing that I learned.
Thank you. So the next question is from Zeynepetka Çelikran. She is a fourth-year medical student at Biruni University. Although these expansions are measurable in cadaveric studies in live surgery with pulsation and bleeding, do they still provide a useful working space, or is the main benefit the improved angle of approach? Yeah.
Obviously, thanks, Zeynep. Like I said, we have limitations. We don't have CSF, we don't have blood, we don't have pulsation, and cadaveric tissue is very hard. And sometimes it depends on the formalin fixation time. Let's say you fixed the tissue 6 months or a couple years in formalin that you just took out and tried to use in a cadaveric study. So that tissue might have been shrunk. So it means smaller than normal, smaller than usual, and that's a significant limitation that we're having in all these cadaveric studies. We are reporting this at the end of our limitation section always in every single study. Like you said, Zainab, yes, it might be different, but overall, because the intersecting neurovascular bundles are the same, the cranial nerves, sometimes the arteries, sometimes the veins. For example, infragalenic triangle, let's say infragalenic triangle is defined by these midbrain veins, basal vein, Rosenthal, and so on. Those are prone to sometimes prone to variation, but mostly those anatomical structures are the same. So, although it's prone to variations and was prone to be affected by different types of like pulsation, CSF, and so on, the overall shape, the overall frame, I think is the same. At least this is what I was able to see through Dr. Lawton surgeries and all the 7 series videos. I think the overall scenario, overall frame is the same that you can use. Yeah.
Thank you. So there's another question. Ayman Abubekir Hassan is asking if there's any chances of hands-on courses in the US or abroad.
Oh, yes. There are many, but the problem is they can be expensive. So that's a significant limitation. For example, in 3 weeks at Barrow in my lab, we're gonna have a Spätzler microsurgery course. Dr. Spätzler's microsurgery course will be held in Barrow between 7 and 8 January. So I think it's sold out, by the way. So you need to follow the announcements, follow the institution's announcements, like in Stanford, in UCLA, in Barrow, and different institutions throughout the United States. And the significant limitations, they're usually very expensive. I'm going to be in our course because obviously I work in the lab, but normally they're kind of expensive, and you may need to secure some support or grant or scholarship to attend those courses.
Thank you. If there's no other questions. Okay, we have. So there is another comment from Mehmet Çağatay İnce. Thank you for your presentation. In your presentation, you mentioned that during the dissection on the cadaver for STT, you performed the dissection form a point different from the standard procedure. When returning to the standard procedure, do you think there could be a significant difference in the procedure of reaching the desired point during the operation?
No, I don't think so. I think I showed you, yes, about retrosigmoid approach. It was about the skin incision. Actually, if you ever work with a cadaver tissue is very hard, and sometimes retracting is problematic. And other limitation of me is I usually work alone, so there is no retracting person or there is no assistant in the lab that can help me. So sometimes it can be very hard to retract the hard tissue. So that's why I may just that's why I use a bigger incision, the hockey stick incision, to be able to reach out kind of easily. But this was just for the skin incision. I did not modify the craniotomy or I did not modify the approach. It was just about the skin incision for the feasibility stand of view for since I was working alone. And it's been also said in the article that I modified the skin incision, but I don't think it affects the measurements.
Okay. Ayman is also asking about the hands-on courses in Turkey or India. So I think Professor Suju would know something about this.
He should follow the Turkish Neurosurgical Society website. I am sure that it will be some courses there. I advise him to follow the Turkish Neurosurgical Society website.
Yeah, I think they are also organizing like neurosurgery student camps for like fourth, fifth, and sixth year students. I'm not sure when that's gonna be, but I just remember that the last year it was in Bursa like all the time, and it was around March. So yeah, it would be better if you could just follow the website and like the website of Turkish Neurosurgery Academy, like something like that, if I'm not mistaken.
Yeah.
Do we have any other questions in the chat?
No.
Okay,
You finished all the questions and comments.
So if there are no further questions, then we will conclude today's session. On behalf of everyone here, I'd like to sincerely thank Dr. Kıvanç Yangı for sharing his expertise, meticulous anatomical work, honestly, and valuable insight with us this evening. It was truly a privilege to host this lecture. I'd like to also thank all the participants for their active attendance and thoughtful questions. And I'd like to now invite Professor Hasan Kamil Sucu for his closing remarks.
I want to thank again Dr. Kıvanç Yangı for this excellent lecture. It's a high-end lecture indeed. And I want to thank everyone who joined us this evening. I hope to see you in real life soon.
Of course, thank you very much.
Thank you.
It was my pleasure.